Hello, everyone. Welcome to this first experiment about this conversation with me and Felice D'Arco. This is Gennaro D'Anna from Legnano near Milan, and I'm so happy to be involved in this funny conversation about pediatric neuroradiology with Felice. And thank you, Felice, for inviting me as a guest in this video.
Thank you. So, what are we going to do?
Well, what about, first of all, what about the weather in London? I suppose it's not the sky from your window.
No, that's
Unfortunately.
just a background, a virtual background, because the weather is miserable as usual, and that's
So
weekend.
I think we can start. So
Yeah.
please share your screen, Felice, and let's start with this funny conversation about some many interesting cases on pediatric neuroradiology and the discussion. As many people may know, I'm not a devoted pediatric neuroradiologist, but I'm so happy to discuss with Felice these cases. So let's start, Felice.
All right. Yes. So basically, these are some cases of pediatric immune-mediated encephalitis. I was supposed to do this case-based lecture in the Italian Society of Pediatric Neuroradiology, but then there was not much time, so I had to just stick to the basics. But these are really clinical, interesting cases, and they are, as it's written here, about the importance of being clinical radiology. So basically, I will show some cases to Gennaro, and we'll see how he reacts.
Oh, well.
So, first case, this is the cluster 1, and it's about the relationship between the virus and the immune system. Gennaro, what do you see here?
Oh, yes. Well,
That's a brain.
I
That's a
see.
brain, by the way.
Oh,
Child
I
brain.
can. Okay. After first impression, I would like to call Felice for for a consultation. But what I see is a swelling of a brain, of the left brain on frontal lobe, especially for the temporal lobe. With in the non-contrast the sequences with restriction in diffusion, especially targeted to the cortical and just subcortical gray matter. And also on a CT scan, I see a swelling and a loss of white-gray differentiation in the frontal lobe and in the temporal lobe.
That's very nice. That's very nice. You look almost like a pediatric neuroradiologist, Gennaro.
Well,
Yeah, you just missed a bit of hyperdensity here. That was a bit of
yes,
yeah. So
yes.
acute changes. This child had was encephalopathic. Acute changes. So this is an encephalitis. Now, when we do encephalitis, we check for viruses and for autoimmune encephalitis. And in this case, what we had is that, oh, this is the clinical status, febrile generalized seizure. And we have that Herpes simplex virus was found on PCR in the CSF, and there were no signs of autoimmune encephalitis. In particular, anti-NMDA receptor antibodies were negative. So this was diagnosed as herpes simplex virus encephalitis.
Well,
And
so easy.
yeah, very easy, right? And therapy is acyclovir, and the child is better. This is the child in August. So 1st July, after acyclovir, the child improves and is discharged. And then in August, he came back in the emergency department with, again, lethargy, psychotic episode, dyskinesia. So again, encephalopathic, a bit worse than before. And yeah, you remember the first scan. Tell me what's different now in this
Well,
news.
I see some regular radiologic evolution, I see many the same extension of the previous swelling. Now is chronic changes both on frontal and temporal lobe on the left, but I see some of cortical necrosis, no acute signs, I suppose.
Yeah, no changes. Yeah, you are right. I mean, I didn't show the diffusion, but there were no acute abnormalities in diffusion. So basically, this is very interesting example of a negative, non-negative scan in the sense that there is nothing new, just expected evolution of the previous changes. So in terms of new findings, this was negative in the sense that we didn't find anything else than the expected evolution of previous damage in the brain. Now, the problem is, so what you do with that? Because we like to spend a lot of money in lab analysis here, we did again the same evaluation. And we found that HSV in CSF was completely negative. And here we have anti-NMDAR antibodies positive. So what is that? A cross reaction or what? Now becomes a bit tricky. Do you want to call someone?
Well, now it looks more interesting compared with the previous slide.
So
what's going on?
Do you think we were? A question for you. Do you think we were right before and wrong now, or vice versa? This was originally an autoimmune encephalitis and not a viral encephalitis. What do you think?
Well, this is a question that I would like you will do an answer because the radiologically is the previous slide was very clear. We found a classical HSV, herpes simplex virus and encephalitis, and so now these lab results are so strange.
So
yeah, absolutely.
For the first time, or one of the few times, we were right both of the time, because we were right at the beginning. This was an HSV encephalitis that triggered an autoimmune encephalitis. So this is an autoimmune encephalitis. We do prednisolone, and we will have clinical improvement. And this is the paper you should read, Gennaro, when you are not busy with all the presentation and moderation you are doing for a lot of international society.
Look, okay, so between the 8 and 9 p.m.
Yeah, between 8 and 9 p.m. when the children are sleeping, you can read this paper that shows exactly that. Look, same cases, acute changes, sequela, chronic sequela, so atrophic changes in the brain, but nothing new. But the child is much worse, so has a second event of encephalopathy. And this is because herpes simplex virus can induce NMDA receptor encephalitis. So virus and immune system, as we know in the current COVID crisis, are very well linked. What else is important? Yeah, the clinical scene changes a bit. So the autoimmune NMDA receptor encephalitis has more presence with more movement disorder and does not have new necrotic hemorrhagic changes. And of course, as we saw, the HSV PCR will be negative and positive with positive anti-NMDAR antibodies. And the therapy is acyclovir for the virus, prednisolone for the autoimmune encephalitis. This is very, very important when you are dealing with the second event of clinical event of HSV encephalitis. Just to give you a general interesting overview of the interaction between virus and immune system. Well, we can have the biphasic disease, as I showed you. So you have HSV and then an HSV-induced anti-NMDR encephalitis. But you can also have herpes simplex encephalitis with concomitant detection of anti-NMDAR antibodies. We don't know why we have that, but probably there is a pathological role of these antibodies in the herpes simplex encephalitis, but this role is unclear. We also have a third possibility that we have patients that clinically fits anti-NMDA-R encephalitis, but they have concomitant detection of HSV in the CSF. So we have a very confusing picture, and this may be a lab error or previous HSV infection triggering NMDAR without being detected. So as you can see, we have a different combination, but number one is the most interesting for us. Okay, any question about that, or we can go for the cluster 2?
Well, it's better than a question is the consideration, because
I shocked you, huh?
First reaction, shock.
Shock. First reaction, shock, like our politician used to say. Anyway, just remember, Gennaro, use corticosteroids for the immune response. Do not think only virus, okay?
Okay.
This is just to show, and this is a slide courtesy from my colleague, Dr. Mancade, that you can have different kind of phases of anti-NMDA-R encephalitis. So you can have living encephalitis, white matter lesion, brainstem, leukoencephalopathy, meningeal and cranial nerve enhancement, and so on and so on. But remember that 50% are negative, like in our case, where the only changes we saw were from the herpes simplex. And clinically, you can have brainstem encephalitis, like in this case, with also limbic system and leukoencephalopathy, but also some NMDA encephalitis that look like this. So very much like ADEM, so acquired demyelination syndromes, or MS. So remember that you have many phases in NMDA-R antibodies encephalitis. This is just for you, but most of the time, or half of the time, they are negative on radiology. Cluster 2, yeah. Do you want to read this history?
Oh yeah. This patient 1, 3-year-old, following 4-day history of acute varicella infection, vomiting, neck pain, ataxia, slurred speech, and peripheral lower limb weakness.
That's important.
Very interesting. Yeah. Also because there are lining in red. On admission, hypertensive, tachycardic, initially started on empirical antimicrobials and acyclovir for presumed meningoencephalitis. 1 day after, respiratory decompensation.
So that's a proper mess, isn't it? Yes. Yeah. So let's see the scan, shall we?
Yeah, let's see the figures. So, well, no enhancement after contrast media administration. Okay, starting from the end, I see some hyperintensity on the subcortical, always on left parietal and occipital subcortical.
And cortex as well,
and the cortical as well. I suppose like a press.
Yeah, I mean, actually, I put in red one of the several things, hypertensive. So hypertensive, and these changes in the posterior aspect of the brain looks like PRESS. The problem is that we cannot explain all the other stuff going on, but because there was a peripheral lower limb weakness, we decided to do a spine. And of course, we started to treat PRESS, but the patient also had lower limb reflexia and went worse and worse in the next 2 days, with neuropathic processing affecting the cranial nerves on nerve conduction studies. So we did study the nerves in the spine and in the brain, and this is what we had. You can see here this very striking contrast enhancement of the cauda equina roots. Yeah. The PRESS changes are gone, but this is because most of them are transient, and also the trigeminal nerve are enhancing. So we have nerves and cauda equina enhancement. So how we call this normally, Gennaro?
Well, normally we call the Guillain-Barre.
Yeah, Guillain-Barre or Miller-Fisher variant because of the cranial nerves involvement. So this is a Guillain-Barre spectrum, exactly. So now we have a PRESS and Guillain-Barre spectrum. How we put together the two things? I had no idea. What do you think, Gennaro?
If you have no idea, imagine me.
So luckily we have good neurologists, and I have to thank my friend Mario Scaleacazzo. He's a Greek neurologist, and he does a lot of research, paper research. So he finds always the links, and actually, so this is our diagnosis. And Gennaro, you are quite good for an adult neuroradiologist. You did all right so far.
Well, I have a good suggestions from you in the preparing this video. Don't worry.
We saw the presentation first. We have to say, but yeah, it's okay. And I read the paper beforehand, so we are cheating somehow. But yeah, so this is a companion case, similar kind of syndromes, including the hypertension, a bit less pronounced PRESS, but again, Guillain-Barre-like changes in the spine. And this is the case report of these two cases presenting with Guillain-Barre. And we know that Guillain-Barre normally does not present with dysautonomia, but sometimes we have an atypical presentation of Guillain-Barre with dysautonomia. So if we try to be clinical radiologists, we have sometimes. Yeah, sometimes we need to try. Because of dysautonomia, they develop hypertension, and because of hypertension, they develop PRESS. So this is actually the reason why we have a PRESS with Guillain-Barre changes. And this is our clinical radiological reasoning. So first of all, you have dysautonomia. Okay, dysautonomia can give you hypertension, and hypertension can give you PRESS. But dysautonomia, as we saw here, can be also a rare cause for symptom of Guillain-Barre and Miller fission. So you have that this is basically an immuno-mediated PRESS. So that's nice, and you know, it's good to think out of the box in these cases, especially in pediatrics. We have a lot of this strange connection. So that's a case that taught me a lot, and this is our second cluster. Just a few companion cases. What's the difference here between this one and the previous one?
Well, I see some, especially in the axial T2 weighted. I see also the enhancement of the cranial nerves, the cauda equina. Also a spot of myelitis on the left, and
that's the difference. But the cauda equina looks very similar. So we have again enhancement of the cauda equina. And yes, plus myelitis, this was a virus. So remember, guys, enterovirus can give you enhancement of the cauda equina plus myelitis, very similar to Guillain-Barre, just without the myelitis or changes in the cord expected in Guillain-Barre. This is the basic of differential diagnosis. And these are the other changes that we found, we can find, especially in the brainstem. We saw posterior brainstem in enteroviruses, and also sometimes we can have changes in the cerebrum or cerebellar hemisphere. So remember this constellation of findings. So think also encephalitis, not only Guillain-Barre when you have enhancement of the cauda equina. Also some neurometabolic disorders can give you a cauda equina enhancement, like for instance Krabbe's or MLD, metachromatic leukodystrophy. So you see something very common in Guillain-Barre, but you need to consider the whole spectrum of changes. But the relationship with PRESS is quite unique. So that's our cluster 2. This was another enterovirus.
Another enterovirus, and always think out of the box.
Always. So yeah, this is just to show you
another paper suggestion, another paper to read between the 8 and 9 p.m.
Yeah, very busy time for you, huh? Isn't it?
Well, it's a very tough time for me.
It's study time. Cluster 3. Go on, Gennaro, do this amazing diagnosis. I know that you forgot already what we discussed, so yeah, let's see.
Okay, 8-year-old girl, left-sided focal seizures and hemiparesis, uveitis, and cognitive decline. She had chorioretinitis from the age of 6 months, considered secondary to congenital infection. However, no pathogen had been identified. There was no history of systemic symptoms, and she had occasional mouth ulcers, but not genital ulcers.
So I put in
other
red.
other interesting findings. So let's see the images, please.
Yeah, so focal seizure, we did the brain, but yeah, there are findings of infection without an infection that are always triggering something strange going on and autoimmune going on. So what do you think of this?
Yeah, starting from the end, as usual, I see an enhancement on both on the thalamus on the right and cortical, subcortical around the paracentral lobule,
Yeah.
so pre-Rolandic and post-Rolandic cortex, and I see also some hyperintension in focal area with focal hypointension, central hypointension on the right thalamus and the subcortical in the precentral cortex, the white matter, subcortical white matter. So very interesting.
So everything that is enhancing.
What do you do in this case, Gosh?
We just like to do a lot of holes in the children brain and have a biopsy for everyone, sometimes to consultant as well. Just one small correction to just one small correction to your English is hypo-intensity and hyper-intensity, because hyper-intention and hypo-intention is what we are going on during the day, you know. Like I have very hypo-intention of doing this presentation on a Saturday, for instance. But
I thank you for the correction, and
yeah,
it's also the way to be very funny with this recording. So I have no problem to show my macaronic English.
Yeah, and you can change the recording and put a lot of bad words on my after in post-processing, so it's okay. By the way, we did the biopsy, granulomatous inflammation, so it looks like tuberculosis, and we treated for tuberculosis. Just the child went worse, as you can see, enhancement increased, edema increased, so clinical radiological progression. So the only thing we could say, it looks like granulomatosis process because typically a granuloma is T2 hypo-intense and shows enhancement. And this was confirmed somehow in biopsy, but both radiology and biopsy were not very useful because empirical treatment for tuberculosis didn't work. So we did a second biopsy, as you can see, and it shows again necrotizing granulomatous inflammation, but no infection. So we are sure that we are dealing with something else. Now, if it's granulomatous inflammation, no infection, think autoimmune, and negative body fat.
Fantastic.
That?
Well, calcification.
Yeah, little shiny guy in the brain. I don't know why they did a CT, but they did it well because CT is very sensitive for small calcification. And when we have a granulomatous process plus calcification, we think without context, outside the context of infection, we think Guillain-Barre. And so they thought, well, maybe this is an interferonopathy. Very bold reasoning by our rheumatology team. And neuroinflammatory team, and they started JAK1 and JAK2 inhibitor that are to block the interferon cascade, and the child was like that, much better. This is how the clinicians are teaching us a lot about clinical reasoning. And look, it is so good. And we did this empirical diagnosis because of CT. This is why it's so interesting, this case. So clinical radiological improvement, and they found the TNFA IP3 mutation, which is one of the genes involving the interferonopathy. And remember, Guillain-Barre is the original name and then was discovered to be an interferonopathy. And that's the paper. You can see they found this heterozygous loss of function in TNFA-induced protein 3, so this gene I told you, that cause autoinflammation. And this was also the cause of the oral ulceration and uveitis. The central nervous system is reported as very rare. So we found this new association, and Despina was the senior author of this paper, that allowed the child to be treated thanks to this JAK inhibitor. So very interesting. Again, we need to think out of the box, but also we need to ask excellent clinician, because no one could easily
Absolutely,
do.
and another paper to study during the
Yeah, that's
night.
a small one though, so this you can do. All right, cluster 4, I gave you a hint about that. So
Brains on fires.
yeah,
What's the
so there are 3
fires?
patients. I will ask you to comment all 3. First patient, what do you see? This is a DWI. What do you see?
Well, some restriction in the basal ganglia, and also in subcortical, in the cortex of hippocampi,
Yeah,
and
yeah,
also the temporal parietal and temporal parietal cortex,
yeah. This yeah,
both sides. And
yeah.
also in on the occipital left occipital cortex.
Maybe, yeah,
I
yeah.
suppose maybe
Yeah, it can be an artifact, but yeah, the basal ganglia and thalami and hippocampi are for sure. And then we did 10 days and look at the diffusion.
well, it's very more clear for the thalami involvement, and also the cortex.
Very striking, very striking. So yeah, so basically this was the first case. Okay, restriction means acute changes. The child has seizure. We don't know. This is not an ischemia, an infarction like you see in adults with stroke. This is a generalized process. Okay, patient 2, what we see again,
Well,
diffusion T2.
basal ganglia restriction with exactly both caudatus and especially putamen. And on the 4-week follow-up, I see also an involvement of both thalami.
Yeah, yeah. So there are scarring here. So, very good, Gennaro. You should come and do a fellowship in our department. We are very funny. So
Well,
you will learn a lot.
I suppose too.
I
Could
think
be
your
great.
wife would be not happy with me.
I'm not so
You
sure my
come
wife
6
will be
months
so happy.
in London. Yeah, probably let's stuck with the webinar for now. And patient 3, that's a bit tricky, but yeah, still diffusion NT2.
Yeah, yes. So smooth the signal alteration on both thalami with some restriction on the VI, and also, but I suppose is, and also restriction of the cortex.
Yeah.
And also I see in the 1-year follow-up, I noted a ventricular dilatation, and also the cerebellar involvement is
Yeah,
very,
yeah.
very high.
So yeah, that's so we have 3 patients, okay, with acute changes in diffusion restriction, status epilepticus, all 3, and a follow-up where the areas that showed restriction now evolved in atrophy. So with atrophic changes, and this is quite interesting. And yeah, so I think the problem is the status epilepticus, and these changes we call seizure-related changes, whatever it means. But we have an acute phase, status epilepticus, and diffusion changes, and then atrophy. And some of the children with this condition will die. And the name of this condition is FIRES. This is why I wrote the brain on fires, which means febrile infection-related epilepsy syndrome, which is a severe epileptic syndrome occurring in previously healthy children and characterized by refractory status epilepticus following a febrile illness. This is just a definition, okay? Do you want to say something about this fires?
Well, very interesting, and but my attention is related especially to the second author of this paper, Giacomo Talenti. Hello, Giacomo. If
Yeah,
you
our good
see
friend
us.
from Verona, from north of Italy, who was a fellow, visiting fellow at Great Ormond Street, and with another fellow from Ireland, Sinead, they wrote this review that you can find on epilepsia. And these are 2 neurologists working with us. The interesting thing is that there's a lot of discussion, what are the seizure-related changes and why some disease, especially triggered by infection, so autoimmune seizure-related changes create changes in the brain, while like a focal cortical dysplasia, other kind of intractable epilepsy do not cause these acute changes. We don't know why. The important thing about FIRES, this is an umbrella term, it's just a definition, but often these children are normal on admission, then they develop these acute DWI changes, and then they go to atrophic changes. And this is a very good review related to peri-ictal MRI changes. So bear in mind that not everything that is restricting is just an acute arterial ischemia, but you can have these seizure-related changes, especially, at least in my experience, in seizure triggered by infection and inflammation. So cluster 5, these are 3 patients again to make it faster. What do you see?
Yeah. Well, in the case 1, 22-years old man, progressive symptoms after recurrent illness, speech regression, progressive left hemi, and swallowing difficulties. Case 2, 5-years old female, subacute presentation, speech regression, left side weakness, plus false, and swallowing difficulties. And the case number 3, 4-years old female, progressive 1-year history, speech regression, walking difficulties, and false, and swallowing difficulties. I see motor difficulties in general, and also speech regression.
Yeah, subacute history. Yeah,
exactly. Not
very similar,
not acute. Very, very similar, but with very different in age of the presentation. Let's see the images.
So let's say that the scan is kind of so the clinical presentation is non-specific but very similar, and imaging are even less specific. How you will call this, Gennaro? These are the 3 patients.
Well, quite normal. I would like to see a non-specific ventricular enlargement, but very low. Some exactly.
This is how I reported. So mild non-specific enlargement of the lateral ventricle.
And the sulsa, and no other to say. They're almost normal with this non-specific enlargement of the sulci and the lateral ventricle.
This is when a clinician hates us, when we write this completely non-specific reports. But then the interesting thing in this case is actually that we have a non-specific, let's say, brain atrophy with a non-specific clinical findings, but they look all very similar. So there is something going on. And again, we do biopsy like we do to everyone. No, jokes apart, this is the right things to do, but we have chronic inflammatory cells, T cells and microglia. So it's an inflammation with raised neopterins and raised interferon stimulated genes, despite all the known infective inflammatory and neurometabolic etiologies were negative. So this is again something that looks like autoimmune process, and again related to the interferon cascade. And so again, we need to reflect on the correlation between radiologies and clinical symptoms of the patients. We have 3 patients with similar clinical symptoms, with similar appearances of the radiology, and similar, although all non-specific, laboratoristic findings that suggest an inflammation and an activation of the cellular immune system. So the diagnosis was a clinical diagnosis based on all these findings we described of immuno-mediated neurodegeneration with systemic and central nervous system inflammation. And what we do? Well, we do cortisone in this case. So
as usual,
we like cortisol. And look at the brain. It completely regress the atrophy, and the child are much better. I remember a funny story about this, that we were doing biopsy and speculating, and one of this is a story that the neurologist Marius used to say, and he was speaking with the neurologist in Poland. The neurologist in Poland said, "Ah, very nice, good investigation, but I just put some cortisone and the child is walking now again." So he just treated him empirically
Wonderful.
before. Yeah, before our bold diagnosis. But you know, and this is the
Another
paper.
paper.
Yeah, another paper to read, but I'm summarizing for you, so I think you know, you can go with this presentation, can't you? And yeah, so remember, neopterin is a catabolic product of GTP, and is a marker of cellular immune system activation, and interferon stimulated gene is a gene whose expression is stimulated by interferon, as the name says. So this presentation could indicate a genetic type 1 interferonopathy, despite we couldn't find the gene, but we know that there are a lot of genes that we don't know about. They are not in the panel. So this doesn't exclude the diagnosis, but it's very important. Again, another kind of clinical radiological reason. So that's the end. I don't know, do you want to say something, Gennaro? Let me stop sharing and come back to you. Did you like these cases?
Wow, really, so much. I learned so many interesting things. First of all, put prednisolone to everyone, and
brain
you will
biopsy.
live, and perform brain biopsies to everyone. No, I'm very happy to discuss these cases. Are very interesting. I learned so much, and I think it could be the first of many appointment with you to discuss other cases. Very interesting. And I also all the people viewing this video enjoyed this discussion, and also the material you proposed with many interesting papers.
We can put the paper, the link to the paper to the YouTube channel.
Absolutely.
And so,
Absolutely.
thank you very much, Gennaro, and I will see you next time.
Okay, thank you, Felice. Thank you to everyone who followed this video, and see you next time. Bye-bye.